Hello and welcome to Conversations in Interventional Cardiology. My name is Sandeep Nathan. I'm a professor of medicine at the University of Chicago in Chicago, Illinois. I also serve as one of the associate editors for SCAI, and it's truly my honor to represent SCAI in this endeavor, as well as editor-in-chief of SCAI, Dr. Alexandra Lansky. You can find us online at jsky.org, or you can follow us on X, formerly Twitter, at myJSky. JSky is the home of all SCAI clinical documents. We're here today to discuss a very important paper that's being published in JSky titled National Trends for Temporary Mechanical Circulatory Support Utilization in Patients with Cardiogenic Shock from Decompensated Chronic Heart Failure: Incidence, Predictors, Outcomes, and Costs. I'm joined by an esteemed panel of experts in the field. Dr. Supriya Shore is an assistant professor of medicine at the University of Michigan in Ann Arbor in the section of heart failure and cardiac transplant. Dr. Alex Truesdell, co-director of the Multidisciplinary Cardiogenic Shock Service at Inova Heart and Vascular Institute in Alexandria, Virginia. And Dr. Babar Basir is the director of acute mechanical circulatory support at Henry Ford Health System in Detroit, Michigan. Welcome, everyone. In the next 15 or 20 minutes, we'll be discussing this paper, but I'm going to turn it over to Dr. Shore to start us off with a brief presentation and take us through some of the highlights of this important paper. Dr. Shore?
Thank you, Dr. Nathan, and thank you to JSky for both publishing our paper and for this opportunity. First, I'd like to start off by thanking all my co-authors. This was truly a group effort on our behalf. So we started off this project mostly because we have in the last several years seen a sudden increase in the temporary mechanical circulatory support devices that are available. And as a heart failure doctor, I certainly did feel that we were using more of these devices within our field and within our population. But when you do a literature search, most of the data is based off use in patients with either acute MI or high-risk percutaneous coronary intervention. So we basically aimed to describe trends for use in temporary mechanical circulatory support devices in patients who had heart failure-associated cardiogenic shock. We wanted to describe predictors of the type of device used in real world and also describe how each device was associated with specific outcomes. And the outcomes we chose were 30-day mortality and in-hospital bleeding and in-hospital stroke risk. We also aim to describe hospitalization costs associated with each device type and examine the correlation between costs and outcomes for each device. So for our data, we use the Optum Clinformatics, which is a large administrative healthcare data set, and it has over 80 million insured patients within it. It captures fairly granular data on all clinical diagnosis, inpatient, outpatient codes, as well as procedural codes for all patients who are enrolled. We specifically restricted ourselves to all adults who were within Optum between 2010 and 2019 and had ICD codes for heart failure with cardiogenic shock, but did not have any codes corresponding to that hospitalization where temporary MCS was used for either acute MI or PCI or cardiothoracic surgery. And we specifically wanted to exclude this cohort, this population from our study because there's fairly extensive data, specifically more recently, that describes outcomes with temporary MCS within this cohort. Our devices of interest were intra-aortic balloon pumps, Impellas, and ECMO. And so I'll start off by first showing trends in the temporary MCS device use. So the x-axis is the year of study and the y-axis shows the number of devices. Each bar shows the number of devices used per year, and the gray section is ECMO, orange is Impella, and blue is intra-aortic balloon pumps. And as you can see, overall, temporary MCS use is on the rise within this cohort of patients with heart failure and cardiogenic shock. The largest increase we noted in proportion was for Impella, which was an increase of over 300%, followed by an increase in ECMO, which was of an increase of more than 100%. When we look specifically at predictors for the type of MCS used, valvular cardiomyopathy was by far most commonly associated with intra-aortic balloon pump use. But there were other markers of a higher comorbidity burden and a higher illness burden, like acute kidney injury or presence of cachexia, that correlated with ECMO or Impella use as compared to balloon pump use. In this figure, I'm showing all the data that we noted for each device type and outcomes, and these are the raw rates that are not adjusted. So starting with the 3 bar graphs on the most extreme left, 30-day mortality observed was highest for ECMO, which is the gray bar, followed by Impella, which is orange, and blue, which is intra-aortic balloon pumps. And when we did a multivariable adjustment, we noticed that this difference persisted. So the 30-day mortality persisted to be highest with ECMO when compared to balloon pump, but between Impella and balloon pump, there was really no difference. When it came to bleeding, we again observed that the bleeding rates were highest for ECMO, and similarly, stroke rates were highest for ECMO, but these differences really disappeared when we did our multivariable adjustment. What is important to note is that we looked at rates for complications per device across the entire span of the study from 2010 to 2019, and outcomes per device have really not changed, whether it's 2010 or 2019. Survival, bleeding, and stroke risk for all of these devices were similar across that entire decade. We further went on to look at costs associated with each hospitalization where the temporary MCS device was used. And we again noted that ECMO had the highest cost, with the median cost per hospitalization of $191,000. The cost for balloon pump and Impella were fairly similar with no statistical significance, still pretty expensive hospitalizations. When we looked at how costs correlated with the outcomes, we noted that costs correlated very strongly with stroke and bleeding risk. But when it came to 30-day mortality risk, there was absolutely no correlation between cost and survival. Over the entire span of the study from 2010 to 2019, we noted that hospitalization costs for Impella and ECMO have declined over the 10-year period, but there has been no change in costs associated with Impella for the hospitalization. In conclusion, temporary MCS use in heart failure cardiogenic shock is on the rise, and we noted that the largest increase was for Impella, followed by ECMO. Patients who received ECMO had a much higher comorbidity burden to begin with and a higher 30-day mortality. We noted no difference in the 30-day mortality between Impella and balloon pump. Costs associated with temporary MCS use was highest for ECMO, followed by Impella, and last for balloon pumps. The cost for a temporary MCS hospitalization correlated very strongly with complications of stroke and bleeding, but not with 30-day survival. And I will note that we're limited by use of claims data for this study. Thank you.
Thank you very much for that summary, and congratulations on the paper. Alex and Babar, you were a co-author on this paper, but this is national claims data. Let me open it up to both of you guys. Does this square with what you're seeing in terms both of the rise in heart failure, shock hospitalization, the mortality, and the use of the different devices at your own institutions?
Yeah, I think we have a really a thriving shock program, and it's the driving force of shock in the current era is actually both chronic heart failure shock and actually valvular shock, more so than the classic AMI shock that we study. And what was really interesting about this study in particular was that all facets of hemodynamic support were increased. Balloon pump use was increased, Impella use was increased, and ECMO use was increased. And I think what's happening is that we have more comfort, a broader adoption for hemodynamic support devices. And so there are more clinicians who are using these devices. And it's similar to what happened in TAVR. People thought that maybe when TAVR became available, that it would decrease the number of surgical aortic valve replacements that took place. But we know years later that actually there was a rise in both TAVR and SAVR, more patients were treated. And I think that's what's happening in heart failure shock. We're having increased use of all these devices, but what's happening is more patients are being treated.
Alex, you agree with that, or you want to add to that?
Yeah, no, very similar observations. I was looking back at data at Inova 2017 when we really had our first year of our shock program in earnest. We had like 120 or so patients, and I think it was about 65-70% acute MI. So we had over 400 something shock patients in 2022. We have more for 2023, but I don't have the exact number. But that in 2022, about 65% were heart failure. So we really had a complete switch in addition to the growth. I think what was also interesting, and Babar pointed out that all of the devices rose together. This is observational data, so we don't know, but one would hope, there's more collaboration here between heart failure, critical care, interventional cardiology. There's more SWAN use, and hopefully there's more tailoring of therapies. And I think one thing that's borne out by that is, we reported the death of balloon pump. Balloon pump doesn't work. And then you've seen balloon pump dip down, and guess what? Balloon pump came back up too. I mean, we are heavy users of balloon pump in the, heart failure, non-MI heart failure population. And that was interesting, observation. As Babar mentioned, all devices rose. There's a lot we can't read into it from observational data, but I think the balloon pump observation was important because we, and I know a lot of other centers, are high users for this heart failure population, particularly the chronic heart failure that have a more acute decompensation and just need a little bit of back baseline or near to their line to figure out recovery or advanced therapies.
Yeah, I think that's such an important point that you made, Alex, that, balloon pumps are being utilized in this population. Sometimes I think, cardiogenic shock as a diagnosis is sort of unfairly dumbed down. And there are so many phenotypes and sort of subphenotypes. And for the chronic heart failure patient, there's been a couple of excellent papers in the recent past suggesting that perhaps, these are the actual responders to balloon pumps. We're throwing them, historically, we've thrown them in AMI shock, and we know that offers very limited support and doesn't really impact mortality. But these folks who have dilated ventricles where the stroke volume, even adjusted for their low EF, is a larger stroke volume, there's more blood actually exiting the aortic valve to be moved around by a balloon pump, and perhaps even stave off, cardiorenal syndrome and things like that. This may be a good use. Let me ask you, Supriya, the sort of $1 million question here. There's been increasing use of more supportive therapies. And as Babar mentioned, perhaps more collaboration between the different tribes that sort of that take care of these patients. Why do you suppose there hasn't been sort of the change in survival that we would like to see? Is this in an observational data set, or are we just looking at selection bias where we're reserving the most potentially impactful therapies for the sickest patients? Is it something else? What do you think?
So I think one, there's definitely a selection bias, like patients getting ECMO were amongst the sickest. The other thing is when you looked at predictors of outcomes, there were some things that starkly stood out. For example, age. So if you were over the age of 70, your odds of surviving a hospitalization with temporary MCS and heart failure shock was your mortality risk was over 3 times higher than if you were under the age of 45. So I think it goes to speak about how important it's to select the appropriate device for the appropriate patient as well.
In these kinds of data sets, sometimes there isn't the granularity to be able to sort of make these temporal associations also, but I'm going to ask the question anyway. Was there different sort of timeframes in which one type of device was implanted, meaning did balloon pump patients get their therapy earlier because, hey, it's just a balloon pump, it's so easy to put in? Can you talk a little bit about that?
Do you mean hospitalizations where patients receive more than one temporary MCS?
That's another question, yeah. I mean, that, and also, in this data in Optum, do you have the granularity to be able to say when in the course of therapy in each individual device was placed.
Yes. So we have date the device was implanted. So we looked at all outcomes following that date. So if somebody had a bleed or stroke prior to that, that would not be included.
And then back to the question that you raised, multiple devices. How was that handled here?
So we didn't know how to handle it, honestly. And so we thought, to avoid bias, we should just exclude those patients. So if somebody had a balloon pump and went on to get an Impella, we did not include those patients.
Okay. And how about ECPella? How about the same thing?
So for anybody who got an ECMO, whether they had it with a balloon pump or an Impella, we counted them in the ECMO group.
Babar, you mentioned about valvular cardiomyopathy. Talk a little bit about that. What are you seeing? And Supriya, how what was the predominant valvular cardiomyopathy that was found in this data set?
So it was mostly mitral valve cardiomyopathy. Again, because of claims data, we're so restricted, it doesn't quantify if it's severe or extent of severity and for what kind of valve there was. But by far, when we drill down into the subcodes, they were mostly for mitral valve lesions.
And I think that makes sense because when you looked at the intra-aortic balloon pump use, it was used more in that setting. We would assume that's related to mitral regurgitation. A balloon pump decreases afterload and probably is a very good choice for those patients, right? And so, there's a lot of assumptions being made, and it's challenging to do that within this cohort. One of the limitations, for example, in Impella use is that we don't have a great idea of whether it was an Impella CP or an Impella 5.5 that was used. And clearly they're giving very different circumstances, not just in terms of how much support's used, but even percutaneous versus surgical options. And so, I think what this does show very nicely is that over the last 10 years, we've had increasing use of MCS. In general, outcomes have been very similar, and we're treating more patients. And one may assume that we're just actually treating sicker patients. And the fact that we're treating more patients, I think, as a patient population, as a medical field, is a good sign. And that just shows the aggressiveness of which we're able to deliver therapy in the modern era.
I think one other thing, too, again, when you parse out who was getting the different devices. So you mentioned, valvular disease. There's a distinct difference in a percentage of cardiac arrest, right? So again, I think this shows that the cardiac arrest had a 4-time higher use of ECMO compared to balloon pump. And again, this just goes back to no one is saying, hey, this is the one device, this fixes everyone, or this doesn't. And none of this is randomized data. There's a whole nother set of questions, but it is good to see that it appears that different devices were used for different circumstances. Again, I'm drawing a lot of assumptions about the thought process that went into that from a multidisciplinary team approach, from maybe a hemodynamic assessment approach. But I think that, does evidence some of that thought process, and that in and of itself is encouraging as we move forward to tailor our therapies towards the individual patient, their individual condition. And then the last thing, I think the comment about age, in the SCAI shock update, we talked about modifiable and non-modifiable risk factors. So age is a non-modifiable risk factor. The body can tolerate in terms of our therapies, and the illness itself at 45, point out, is very different than 70. And, we can't tell what the decision-making was that drove that, but we can assume how that impacted some decision-making about what therapies were chosen or, not at all.
Well, great. Dr. Shore, you have the final word here. Any final thoughts or directions that this analysis sort of drives us towards for future analyses?
So I think the big picture that I took away from all of this is that perhaps it's time for a randomized trial to truly compare all these devices across each other within this cohort, because we draw a lot of assumptions from an MI PCI cohort, which I think is very different. These are patients who are chronically ill and I think have a different pathophysiology overall.
Wonderful. Agreed. Thank you, everyone, for joining us for a terrific conversation. Thank you to SCAI and to JSCAI.